Mothers are not dying because of diseases that we don't know. We know what is killing our mothers. Mothers are dying because we have not made a conscious decision that their lives are worth saving. Mm-hmm. Can you imagine that? That we don't care. Let them just die. It's just a number. We have not decided that their lives are worth saving. And that is why our numbers are 550. We are just not serious. We get money, we steal money. Money goes into other things than saving our mothers. And by the way, when a child loses a mother during childbirth, this one has been scientifically proven that the effects of that death is actually felt to the third and fourth generation.
Once again, welcome to the Reproductive Health series. If you're joining us perhaps for the first time, this is a space where your health is as important to the conversation. And we have been having very engaging and fruitful conversations around issues of reproductive health with Dr. here, Dr. Kireki,
yes,
who has been very instrumental to these conversations. And today is one of those conversations I've been looking forward to. We are talking about postpartum hemorrhage. And in short, PPH.
PPH, correct.
PPH. And Dr. will be telling us more about that, but basically this is where you find women, especially during birth, childbirth, or after, losing a lot of blood, excessive bleeding. I just want to read a few reactions or feedback from some of our viewers. Correct. In relation to PPH, so that it can give us context as to why this conversation is actually very important today. And one says, I didn't have any complications during pregnancy, so it caught me off guard. What are some of the reasons PPH can happen even if everything seems normal throughout pregnancy? So this is someone who didn't have any complications the entire period, and then somehow, suddenly, things just erupt that are beyond control. And then the next one says, I suffered PPH in my last pregnancy. Physically, I've recovered, but I'm curious, are there any long-term effects from experiencing PPH that women should be aware of? So this speaks to the emotional, psychological implications or effects that are associated with this kind of experience. And finally, the last one says, I bled almost to death. I stayed in the hospital for a while and needed blood transfusion. I got well finally and I was discharged. But even after I went home, I was worried about bleeding too much again. What signs should new mothers look out for once they leave the hospital? I don't know where you want to pick this conversation from so that our audience can have a better appreciation of why this conversation is important today. First of all, introduce yourself to that person who is perhaps watching you for the first time.
Thank you very much, Justus, as usual, for inviting me to this conversation about reproductive health. My name is Dr. Kireki Omanwa. I'm a consultant obstetrician and gynecologist, senior lecturer at the University of Nairobi, Department of Obstetrics and Gynecology. I deal with couples who are trying to get pregnant, what we call infertility. So I'm an infertility specialist. And also I wear the hat of the president of the Kenyan Obstetrical and Gynecological Society.
Very good.
So thank you very much for inviting me once again.
Karibu sana.
It is indeed a good forum and a good platform for us to be able to discuss issues related to reproductive health. And I think the fact that we have chosen to talk about postpartum hemorrhage, it is something which is dear to my heart because of the implications that it has, the postpartum hemorrhage in itself. So when we talk about postpartum hemorrhage, thank you very much for those cases that you've sort of quoted. We'll come to them as we continue our discussion.
Yeah.
Postpartum hemorrhage is basically excessive bleeding of women, either during childbirth or soon after childbirth. Now, normally, when a woman delivers naturally, that is vaginal delivery, she will lose about 150 to 200 milliliters of blood.
That's acceptable.
That is acceptable.
Okay.
That is normal vaginal delivery. If she delivers through a cesarean section, she will lose about half a liter, 500 milliliters. That is, again, acceptable. Remember that the total circulation of blood is about 6 liters. So if you lose half a liter, it's not so bad.
Okay.
200 milliliters, it's not so bad. However, when you talk about postpartum hemorrhage, is when in vaginal delivery, she loses about 500 milliliters or more. And in a cesarean section, she loses 1 liter, 1,000 milliliters or more. Even before we go to the mechanism of how this happens, I just want to just demonstrate how big the uterus is, which is non-pregnant. It's about the size of my hand. That's how big the uterus is. And as I've said, I think once in this series that the psalmist David says we are wonderfully and fearfully made. So imagine this tiny organ will carry a baby, 3 kilos, 3.5 kilos, sometimes 4 kilos.
4.
Yes.
Yeah.
And then apart from the baby, there is the amniotic fluid, which works as a shock absorber for the baby. Not only as a shock absorber, that is the same fluid that the baby swallows and urinates. Now, when we are doing a scan, that is a very important parameter because it tells us about the digestive system of the baby. Because if the fluid is too much, it means there's a problem. If the fluid is too little, it means there is a problem. Either a problem with the digestive system or a problem with the urinary tract system. Remember, that's what the baby drinks and that's what the baby urinates. And then apart from that, there is the placenta. And the placenta is what connects the baby to the mother through the cord. Okay, that is why on our tummies here we have what? Kuna kitovu. Okay, now all these together at the time of delivery, it's about 4 kilos, 4.5. Sometimes it can even go up to 6 kilos or even more. There's a time I was on duty in KNH and we had a patient who had delivered very big babies, 6 kilos the first one. So if the baby is 6 kilos, then there is the amniotic fluid, then there is the placenta. It's about 7, maybe 7.5 kilos. Remember the structure that we started with when the woman is not pregnant.
The size of a fist.
The size of a fist, and then it stretches until it can be able to accommodate the baby, amniotic fluid, plus the placenta. Now, once a woman delivers, what happens is that, remember that placenta has vessels, and it's because through those vessels that the baby gets nutrition and oxygen. They pass through the placenta, through the cord, to the baby. Some of the waste products also pass the other direction and into the mother's circulation and out of the system. So a very complex system, if anything. Now, once a woman delivers, the baby has come out, we wait for a few minutes, and again, it's a natural mechanism. The uterus starts contracting. As it starts contracting, that placenta starts coming out on its own. But sometimes you may need to pull it just a little bit, give it a bit of traction so that it comes out completely. Now, remember we talked about vessels. So these vessels sort of come through the uterus. Now, once the placenta has come out, the uterus contracts. As it contracts, it shuts those vessels which were attached to the placenta, and then that is where the bleeding comes from. And then once those ones are shut, as the uterus contracts, the placenta comes out, and the bleeding is supposed to stop.
Because these vessels are the ones that were
supplying
both.
Yes, through the placenta, the cord, to the baby. All right? Now, in most instances of PPH, you find that the uterus has stretched and the placenta has come out, but the uterus has not contracted, what we call atony. So if the vessels which passed through here and the uterus has not contracted, the vessels will still be open. So the blood will keep on pumping into the empty uterus. And because of that, it will accumulate and form clots, and this will start coming out. Okay? So that is one of the reasons where you find the uterus is extended, it has not contracted, or it does not contract, or it has not contracted properly, and there is excessive bleeding.
Right.
Number two, you may have what we call tears, because as the baby comes out of the womb and through the passage, through the vagina and out, sometimes the baby can be quite big. And the process of delivery is actually a very excruciating process. And first here, I want to lift my hat off for all ladies because of what they go through to become mothers.
Yes.
And then to also give us names, because then we
Right.
become Baba so-and-so and Mama so-and-so, okay? And what they go through is out of this world. And I can assure you, Justus, no man can go through that. So in that process, sometimes the cervix, and the cervix is basically the connection between, which connects to the womb. So if we imagine the womb as a balloon, where you blow in air and then it goes to form the balloon, that we call that the cervix. So as the birth process, continues, that cervix is going to open up. But if the baby is big, sometimes there can be tears on the cervix. So injury to the cervix, injury to the birth canal can also lead to excessive bleeding. Sometimes the vagina itself can be torn, and you may have what you call very superficial tears, which are not a problem. You may have what you call second, third, or even fourth degree tears, whereby the vagina is torn, plus the rectum, and so on. So a complication basically of that. Sometimes you may have tissue which remains inside the uterus. So, for example, the baby has come out, the uterus has contracted, but the placenta has refused to come out. And because it has refused to come out, remember, those vessels are still open. So they continue doing what? They continue bleeding. Okay? And then lastly, you may have a patient who has a problem with the clotting system. So any of these can actually lead to postpartum hemorrhage. The biggest cause is that one of the uterus not contracting enough. And that is one of the biggest problems that we have. Why do I think this is a problem which is people don't know about? And it's a very important issue, is because when you look at what we call maternal mortality ratios or maternal mortality rates, that is when we look at the number of women who die during pregnancy or soon after, up to 42 days after delivery, we are not doing very well at all. The government says that our maternal mortality, what you call MMR, the number of women who die in every 100,000 that deliver, the government says that we have our MMR is 355. We think it's a gross underreporting, because we think our numbers are a lot higher, because when you compare what the government gives us with what international organizations, for example, WHO, UNFPA, UNICEF, they think our numbers are a lot higher, about 550 out of every 100,000 women who deliver. What does that mean? It means that if we were to deliver 1 million women in Kenya, it means that we'd lose anywhere between 3,550 to 5,550. A huge number of women who die.
And this is not just a number. These are human beings.
These are
people.
These are women who have faces. These are women who have families. These are women who have left babies and so on. A huge number. And I think we don't think about it because if we were to take, if a plane was to take off from JKIA today with, let's say, 250 passengers, and then something happened and it crashed, we would actually follow that process. What time did the plane leave? The communication with the tower, control tower. Where was the signal lost? Where was the impact? How many people were on board? The nationalities and the crew and everything.
Yeah.
So, and then we'd be looking for the black box to find out exactly what was the trajectory of this plane and so on. And then there would be a commission of inquiry to try and figure out what was the problem so that these problems could be mitigated in the future. But here we lose almost 6,000 women.
And
have you ever
happens.
heard of any commission of inquiry? No. So it's like taking a plane with 250 passengers, maybe about how many of them? 10 of them would be 2,500. So maybe about 20 of them. And just
planes.
Yeah, and just keep on crashing them intentionally. Crashing them. Get another one and you crash it. And nothing happens.
And no one says anything.
And no one says anything. And that is the tragedy of the problem that we are talking about. It's a very serious problem. And again, personally, I think that even the authorities don't know about this because maybe they are not aware. And maybe because this problem doesn't touch them or it has not touched somebody close to their families and so on. But unfortunately, it's a problem which can touch anybody. It can touch anybody right from the top to the bottom of the pyramid, as it were. So losing anywhere 350, 55 to 550 women out of every 100,000 women who deliver, it's a big problem.
It's huge.
It's a huge problem. But again, we comfort ourselves most of the time. We say, you're not doing too badly. Because let's say the worst country with the worst statistics are our neighbors, South Sudan, with 1,223 deaths out of every 100,000. So we can say South Sudan is 1,200, Sisi to go 355. We are not too badly off. But every death, we should not allow even one woman to die because of this, what we call preventable maternal deaths.
And I like that word, preventable, because the biggest question then would be, so what happens that, it leads to mortality?
There are what we call risk factors, and some of these risk factors, as you remember, we talked about that uterus, tiny uterus, extending and then being able to accommodate the baby, fluid and the placenta. So if the baby is big, and we can actually notice that during pregnancy, during the ANC visits, we can actually know that abdomen looks bigger than it is supposed to be. So when you have a big baby, what you call macrosomia, that is one of the risk factors. When you have more than one baby, you're carrying twins, you're carrying triplets, sometimes even you're carrying 4 babies, quadruplets. That is a risk factor. When the amount of amniotic fluid is excessive, that is also a risk factor. Age is also a risk factor. Young ladies, 13, 14, 15, 16. Yesterday I was on call in KNH, and we had a very young girl, 14 years old. 14 years old. 14 years old. This is a child who is going to give birth and become a parent to another child. It's horrible. Okay. Now, that is also a risk factor. Why? Because their bodies are not yet what? They are not yet fully formed, as it were. If you have older, I don't want to say older because older has different connotations. Maybe mature. Maybe mature ladies, 30-something, 37, 38, 40, over 40. And especially if it is the first timer, that is also a risk factor. If a woman has delivered, more than 4 or 5 times, and when they come, you take the history, you see this is the 5th pregnancy, 6th pregnancy, and so on. That is also a risk factor. Issues of diabetes, for example, that is also a risk factor. When you have what we call preeclampsia, whereby you have an increase in the blood pressure, especially from the second trimester, around 20 weeks, that is also a risk factor. If in the history this patient has had a history of postpartum hemorrhage, and I think one of those cases that you mentioned, there was something like that. That is also a risk factor. So we need to actually identify these women who are at risk of this. And then there's something also. If a patient has fibroids, for example, and fibroids is basically a growth on the uterus, and unfortunately 30 to about even 60% of women of African origin, it doesn't matter whether you are in Kenya, whether you're in Uganda, whether you're in the US or Cuba, whatever it is, so long as you have that, African descent, you have a very high risk of having fibroids. And the fibroids in African women are bigger and there are many. So that is also a risk factor. So once we've identified these women who are at risk, then when they come to deliver, we need to be proactive.
Right.
But then is it always that that we can identify these women? No, because sometimes the pregnancy is okay and she delivers vaginally and she has a tear. And if we don't realize that there was a tear, then of course that will lead to postpartum hemorrhage. If, for example, she delivers and then we don't know that there is the placenta, for example, cannot come out on its own, whereby the placenta is stuck into the muscle of the womb, what we call placenta accreta spectrum, that is a challenge. And it will lead to postpartum hemorrhage. That is why for the women who are pregnant, when they are expectant, it is of utter importance that they should go to, a health facility. They should be reviewed by somebody who is competent, so that we can actually stratify these risks and then follow up these women later on in order for us to reduce our maternal mortality rates.
Yeah. That perhaps has been a challenge, especially in the rural, areas where sometimes maybe those clinics are not prioritized, those visits are not prioritized, and even when they are, some of our health workers or health facilities are not also very well equipped.
That is also true. Very, very true. And I'll give you an example. Not too long ago, I was in one of the hospitals, private hospital, very well equipped. A patient came to deliver. I was in theater doing something else and I had finished my surgical procedure. And I was going out to change so that I could go and do other things. And then one of my colleagues came running and said, please come to theater 3 or theater 4, I can't remember. There is serious PPH. That is an emergency. So I rushed there and I found my colleague really struggling with this patient. He's a young patient, 31-year-old, and she had delivered vaginally and everything was okay. That was her first baby. Now, after delivery, she started bleeding. She had a small tear in the vagina, which my colleague had put a suture and a stitch, and it had stopped bleeding. But she was literally pouring like a tap of blood. There's nothing as scary as that. So I come in and I see my colleague really struggling. There's what we call an abdominal pack, which we use when we are doing surgery to separate, organs in the abdomen. So she would put an abdominal pack in the vagina, and after 2 minutes, it would be completely soaked, and she'd have to remove it because she can't see. So I come in and I ask her, what happened? And she told me, she delivered. It's her first baby. She's 31. And she started bleeding. There is a certain way that we have been trained to approach a problem of PPH. It's an emergency, but we know at the back of our mind you need to do 1, 2, 3, 4. So the first thing, we massage the abdomen. The uterus seems contracted, but then why is she bleeding? I said, okay, let me have a look. Obviously now, 2 eyes are better than 1, or 2 heads are better than 1. So I look at the cervix. There are no tears in the vagina there, but she's actually literally pouring. So I said, okay, let me put my hand inside the uterus and feel. The uterus seems contracted, but I could feel sort of at the back of the uterus like there was a structure there. So my thinking was that most probably there was a fibroid at the back of the uterus and the placenta was lying on top of it. So when the placenta came out, and because the uterus could not contract because of the fibroid, the vessels were open, so they were actually just pouring from there. So I asked the anesthesiologist, have you given medications? A very experienced colleague says, yes, I've given this medication, I've given this and this. In the meantime, we are trained. I can hear that anesthetic machine, tick, tick. The pressure is dropping because of the amount of blood that she has done what? She has lost. So we can actually feel this woman's life ebbing away.
Yeah.
So I asked for something what we call a uterine balloon tamponade. It's something like a balloon which we insert inside the vagina, the uterus, and we fill it with water. And once that has been filled with water, what actually happens, it goes and fills the empty space, as it were, and then blocks the vessels which were open.
Temporarily?
Yes, and then the clotting mechanism starts taking place, and then it will block the vessels from what? From continuing bleeding. There was no uterine balloon tamponade in the hospital. This is a private hospital. Do you have a catheter? A catheter is a tube that we use when doing surgery. We insert it inside the bladder such that we do not harm the bladder. And also at the same time, we'll be checking to see how much urine is coming out, because then it shows us how the kidney is functioning. Do you have a catheter? Yes, there was a catheter. Which said. So now I'm thinking, what can we do to sort of do something to help this patient? But a catheter in itself is not enough. So you need something, because a catheter is a tube. Yeah. But you need something to insert on that catheter so that you can push in fluid to create a balloon, which we can insert in the womb, so that it can go and block the vessels which were open. So I asked for a condom, and everybody was quiet. They said, we need a condom. And one of the ladies went out, and meanwhile here we are struggling. We can hear the blood pressure is dropping. And then after a few minutes, she came back and said, excuse me, I want to say something. This was not in my handbag. We said, we don't care where it was.
It's fine.
Wherever it was, whether it was in your handbag or whatever it was, give it to us.
Yes.
So we took that condom, inserted it on the catheter, used a suture, and we tied it. So we created a sort of a balloon. We inserted it inside the uterus, pumped in about 250 milliliters of what you call normal saline. And guess what? The bleeding stopped. I have never felt relief.
Wow.
All of us were relieved.
What?
So as it stopped, we said, what? So we took another abdominal pack and we also inserted in the vagina, so that to make sure it stays there and it doesn't move. So all of us were relieved. So the patient was taken to ICU. It was on a Friday. And on Monday, she walked out of hospital with her baby. She went home. Now, when she came in to deliver, we normally do a blood test, what we call HB or hemoglobin. Her hemoglobin level was 11.1. When she was taken to ICU, her hemoglobin level was 3. So she had lost about 2-point-something liters of blood. Because, yes, out of that bleeding. So essentially, she was on her way out. So this would have been a classic case of a patient walked in on her own and she left in a casket. Would have been very sad.
That process, what the balloon effect had.
Yes.
So technically, it helped once it was pushed on the walls of the uterus.
Yes.
To more or less stop the bleeding.
Yes.
Or block the vessels.
Yes.
Was that process what then initiated the clotting? The
clotting mechanism, because now no more blood is doing what? Is escaping.
Okay.
So now the clotting mechanism just kicks in and say, because there's blood, no more blood is going out. Whatever blood which was supposed to go out has stopped here. So a clot has started forming. So they start forming clots and it blocks the vessels.
Okay.
And they stop. And then remember their medications as well, which she was receiving, which also contract the uterus. So all these mechanisms together led to the stoppage of.
So how does the contraction happen with the balloon in, or at what point now do you remove the balloon?
Good. Now, the contraction happened. You remember those medications are given every so often. Okay. So to maintain the muscle of the uterus, which is contracted. Okay. Now, once it's contracted, remember the balloon is just here. It's not in the vessel.
Okay.
It's just on the surface. So the contraction happens above the balloon. So we normally leave it for 24 hours, but in this case, we said, let's leave it for a little bit longer. So we left it for 48 hours.
Okay.
So when it comes out, of course, the vessels have contracted. There are clots which have been formed, so the vessels have been blocked. So even when you remove it, there is no bleeding. Yeah.
And due to the amount of blood that has been lost, was there need for transfusion at this point?
A huge amount of blood. We gave her a huge amount of blood because remember, it was 11. Her HB was 11 grams per deciliter. And then by the time she went to ICU, it had dropped to 3. So she needed at least 8 to 10 units of blood to be transfused. Now, you asked whether these are preventable or what are some of the things that can be done to prevent this PPH. This is a classic example. So the first thing, I call them pillars basically. The first thing is the human resource. We were 3 consultants. 1 consultant anesthetist on the other side, very, very experienced, monitoring how the blood pressure was behaving, giving her fluids, giving her medications, and so on, keeping her alive, basically. We were 2 on this other side, trying to find out what is the cause of this bleeding, and we managed to insert, something. So human resource is very important.
Yeah.
Not only just human resource, but very experienced. You've seen this, you've done this, and not once, not twice, you've been there, done that. Okay, so human resource. Number 2, there were medications. This was a private institution. So all the medications that we wanted, we'd ask, have you given this? Yes. 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 So all the medications that we wanted were available and good quality. Unfortunately, in Kenya today, we have sometimes medications which are poor quality, fake medications. In an ampule, for example, in a small, whatever we use, you may find that this one is supposed to have, let's say, 10 units. But when it's really checked, you find it has 2 units. So you give that patient that injection, expecting, something to happen, and it doesn't happen. And you give another one, and you give another one, and then you wonder what is happening. So we have fake medications, unfortunately, and this is actually a big problem to the patients.
I know that's a conversation for another day.
That's a conversation for another day.
But it's very important you mention
It's very
that.
important because there was a study which was done, and it was actually published in one of the most prestigious journals in medicine called the New England Journal of Medicine. And this was called the Emotive Study by some of our colleagues from our department, Professor Qureshi, Dr. Gwako, Professor Osoti. And this was actually done in different countries, in Kenya, Tanzania, Uganda, and so on. And there were over 200,000 patients who were delivering, there was a protocol and what medications were being given. Unfortunately, some of the batches of the medications that were found in Kenya were fake. Very sad. So medications. So human resource, quality medications. Number 3, there was blood. Remember, her HB was 11. She went to ICU, HB was 3. So we had to give her at least 8 to 10 units of blood. Blood was available, readily available. And there are many times when you are in hospital and you're in an emergency, when a patient comes with serious anemia and you say, we need 5 units, you are told you can get 1 unit. What do? So blood. In Kenya today, we actually collect or donate 276,000 units of blood, which is about 60% of what is needed. We need about 500,000 units of blood a year so that we can comfortably help our patients. Now, out of that 276,000 units of blood that is collected, 70% of it is used by women who are expectant and who are delivering. 70% of it. So first of all, we collect a lot less, and then even that lot less, we take almost all of it, and it's still not enough. So blood. We need an ICU unit. Now, in most hospitals, you'll find, especially public hospitals, you find there is a room which is allocated and is entitled ICU, but it's just a caricature of an ICU. It is a room with no equipment. Or you may find there is a room, there is equipment, but there's no personnel. Or you find there is a room, his equipment. There is no personnel as there is no personnel as well. There is no personnel as well. And then the other thing is commodities. See, remember I talked about that balloon, uterine balloon tamponade, and we didn't have it, so we had to improvise. By the way, these are very very easy things to procure, and they're not expensive, but they're not available. I commissioned some of my colleagues from the office, the COGS office, to actually call the county hospitals and sub-county hospitals, the whole of Kenya, 94 of them. And guess what? I think 48% of these hospitals did not want to give any information because they said these are government hospitals and will not give information. So we said, okay, fine. Albeit the fact that they had...
It should be the other way. Government hospitals should be at the first...
Exactly. Albeit the fact that we explained to them, it was a standard approach. We are calling from Kenya Obstetrical and Gynecological Society, and we want to find out, do you know about UBT? Have you ever heard about UBT, uterine balloon tamponade, which is used in cases of PPH? We don't give such information. We are not allowed to give such information, and so on. So about 48. So we are left with 52%. With the 52%, a huge majority of them had never heard about UBT. And when we asked whether they have them, I think almost all of them did not stock uterine balloon tamponades. I think I remember there were about maybe 6 or 7 hospitals. We said, yes, we've heard about UBT, and we actually stock them. How many do you stock? Maybe 1 or 2. Not enough to help. So lack of commodities as well. So you have human resource, you have blood, you have medications, you have ICU, and you have commodities. Remove any of this from these pillars, and we are going to lose women. There are cases, for example, look at some counties. Some counties have 2 consultants, 2 consultants. In a whole county where you have maybe 1 million people, 2 consultants. So these 2 consultants, what are they going to do? Even if they work 25 hours a day, they will not be able to do that. So human resource is a huge factor. And then there is also another factor which is also very important, that the mother can find out that something is happening. But by the time she gets to hospital, the infrastructure is also a challenge. 20 kilometers away, 30 kilometers away, by the time she gets to a health facilities. And you may find in the health facilities, there's actually nothing. It's just a health facility in the name, but there is nothing there. Mommy, here we can't help you. Please go to go to a level 3 hospital, level 4 hospitals, where you have a theater and where you most probably will have somebody who can be able to, let's say, a cesarean section and so on. So when you get to that hospital, you may find there's no blood, medications are not there, or the personnel, or one of those pillars is not there.
Wow.
And there we are. That is why our numbers are where they are, because we are not serious.
We are not serious. I think that's the word. We are not serious.
We're just not serious at all, because 60 years or 60-something years after independence, we should not be having such numbers. There are countries who have 0 maternal mortality rates. For example, Luxembourg doesn't have any maternal mortality deaths at all. Poland has 2. I trained in Poland, and for the 10 years I was in a university teaching hospital, we never lost 1 patient because of postpartum hemorrhage. 10 years, we never lost. That one I know because I worked there. We never lost. But in our places here, every day, a mother passes away. A mother passes away. It's wrong. It's unfair. And one of our former, I think he was president of FIGO. FIGO is the International Federation of Gynecologists and Obstetricians. He was a professor from Egypt. And he said, mothers are not dying because of diseases that we don't know. We know what is killing our mothers. Mothers are dying because we have not made a conscious decision, or we have not made a decision that their lives are worth saving. Can you imagine that? That we don't care. Let them just die. It's just a number. just a number. We have not decided that their lives are worth saving. And that is why our numbers are 550. We don't care. We are just not serious. We get money, we steal money. Money goes into other things than saving our mothers. And by the way, when a child loses a mother in childbirth, this one has been scientifically proven that the effects of that death is actually felt to the third and fourth generation. So you lose a mother today, you grew up without a mother. That effect will be felt to the third and fourth generation. A good friend of mine lost his mother when he was 15 years old. He was 15. So you'd think, 15 years, I mean, you sort of know what life is all about. You have started knowing, what life is about. So it should not really affect you that badly. But he says even today, he's a mature man with children who are grown up. And he says, my mother's death, and actually she died because of PPH, my mother's death affects me till today. And he was 15. What happened? The father, after 1 year, you know how gentlemen are? Was he? Get married. 1 year he got married, started his own life, and life continued. Meanwhile, all those decisions that this gentleman needed help in making it, things which the mother could cushion, could help in and whatever, they were absent. He said, I don't know how my life could have been if my mother had been alive. I don't know. It definitely could have been different.
Yeah.
Definitely could have been different. So we may think that, it's one of those things that happens, but unfortunately, that effect is felt. Third, fourth generation.
And that is why you have been on the forefront, Daktari, to not only create awareness through such platforms, but you've also, I think you're also working on a public event that is going to create more awareness, mobilize more resources towards this, and to make sure that this comes to an end.
Absolutely.
Tell us a little bit about that and how people can be involved.
There is something called SDG goals, which was set by the United Nations. And the SDG goals, basically the 3.1 says that we should reduce our maternal mortality rates to less than 70 in every 100,000. Remember, the Kenyan one is how much? 350, maybe 550. By the year 2030. By the year 2030, which is actually around the corner.
We were having what we were calling Vision 2030, and it sounded like, something that was too far from us.
But 2030 is almost around the corner.
Is.
Now, I'm not very sure whether we can get to that 70 or less than 70 without really, really concerted efforts in that direction, putting those pillars that I mentioned in place. So what we decided as the University of Nairobi, the Kenyan Obstetrical and Gynecological Society, as well as the Midwifery Association of Kenya, is to come together. We put our heads together and we said, people first of all need to know what PPH is all about. And we want to start by creating awareness. And once that critical awareness is met, then it is also easier for even the powers that be to know that there is a problem here. Right. Then maybe they'll allocate, more resources into combating this amorphous, because it's an amorphous problem. So we have prepared a run. It's a short run, and that is on the 6th of October, which is actually next Sunday. 6th of October, we intend to run from Ulinzi Sports Complex on Langata Road, and down the road we go to Nairobi West and we come back. A total of about 10 kilometers. Why are we doing this? Number one, we want people to know about it, to know about PPH. And our aim is for even a nursery school child to hear about PPH and to know about PPH. Because if this child knows about PPH and knows that PPH can actually kill my mother, Then maybe he's saying, Mami, have you gone to ANC? Have you gone to the hospital?
Yeah.
I don't want you to do what? I don't want you to die. For the husbands to also know that please accompany your wife for the antenatal clinic. Go for those clinics, those checks. Ask the doctor or the healthcare, worker questions. We would like the politicians also to know that actually they are losing people who could do what, who could support them. We also like the economic planners to know that when you lose a mother, you actually lose a potential, not even a potential, somebody who has economic value,
Right.
who is adding to society, who is paying taxes and so on. Remember that effect to the third and fourth generation. So if we are losing mothers here, that effect for that economic planner is going to the third and even the fourth generation. So we want to create awareness. The Cabinet Secretary of Health has graciously accepted to come and flag off the race, and we are very grateful about that. We have invited, quite a number of dignitaries. We hope that they'll be able to keep their promise, because it is not only a health workers thing. It also has to have a political, buy-in, as it were, because these are the decision makers. So once they come and they see what is happening, I hope that this message is going to go out. We also want the press to come, because without the press, the media, people will not know about this. So I'm inviting everybody. I'm inviting all our viewers. You can register on www.endpph, and is endpph.com. Very easy to register and come and help create awareness. What is our aim? What is our objective? Our objective is that this is something which you start this year, a very small run, but hopefully next year we want it to go to various counties. And hopefully after 2-3 years, God willing, we want this to be something that is national, such that every year we are going to have, a PPH and PPH run, so that people know about PPH, what should be done and what can be done. And maybe, who knows, this can also be, borrowed by other African countries as well, because this is not a problem which is, for Kenya alone. It's a problem which is basically sub-Saharan Africa. And, sometimes it's good to dream. As our compatriot say that our dreams are valid, we hope that even WHO will take this up and then say, you know what, certain day this is going to be a PPH day or end PPH day, because then it will have now got the sort of exposure that is actually needed. And when we get that kind of exposure, people will come to the table and say what needs to be done. Then we can put this in place, and hopefully by doing that, we will reduce the numbers, or even eliminate it completely.
Yes.
Because that is no mother should actually die because of PPH. Once we've dealt with PPH, we all hope to go into the other causes, which cause maternal mortality deaths. For example, preeclampsia, sepsis, post-abortion complications, and obstructed labor as well. So please come and run. Register www.endpph.com.
Wow. This is one of those sessions that end at a level where you're feeling so challenged. Personally, I think I need to take action now. The immediate one will be to register for the run.
Absolutely.
And then, of course, follow up even with the conversations and put to task those who have committed themselves to actually be part of this process, so that we see to it that everything that the government has promised to do and all other stakeholders are, held accountable, and they actually, do exactly that. Daktari, thank you so much once again for coming. I know there's so much we haven't even talked about, but I think from what we have been able to discuss today, if anyone had no idea what this thing was, I think we're in a good place now, and you know what to do. We don't need to be losing any mother in these kind of circumstances. Thank you so much for your time. This has been the reproductive health series, but before we go, let me allow Daktari, in case someone wants to reach out, not necessarily on PPH, but any other reproductive health related matters, where can they find you?
Thank you very much. My office is located at 5th Avenue offices off Ngong Road, on the 3rd floor, room 314. And the office number is 0780 170 170. Very easy to remember. 0780 170 170. And I'm usually in the office on Tuesdays and Wednesdays in the afternoon from around 2 o'clock.
Right. Thank you so much, Doctor. I'm looking forward to the next conversation. And of course, this has been the Reproductive Health Series. See you again next time, and make sure you subscribe to this channel.